Okay. Good evening. Again, I'm going to encourage any of you guys to put up a question in chat. Christina's going to be monitoring that. Raise your hand, shout out, whatever you would like to do. We're here today to discuss the current state of EM and how it affects you as an EM interested medical student. So happy to see all of you guys here tonight. I wanted to put this up to give you the opportunity. This is a talk really put together, identified to be helpful and requested by medical students, specifically in Florida, because that's who we serve, but the Florida College of Emergency Physicians Medical Student Council. And these will take you to the Instagram and the page. We do a lot of announcements over our Instagram site. So if you have a chance, take a look at that. These are our feature sessions coming up. Have practically one a week in June so that we can get the information out to you guys. So that is also already posted on our Instagram site. I have actually met a lot of you guys already. I'm happy to say, but I would like to introduce myself in case there's any questions or I can tell you anything specifically. But I started my career out as I'm EM trained and started my career out at the University of Florida, where I also had gone to medical school in 2005 and was actually the associate program director when we started the UF residency way back when you guys were too young to know what you wanted to do, but way back then. And I was a clerkship director at that time. We switched UF. The EM rotation became a required fourth year rotation. And then I stepped away from associate program director and did some research and had some grant supported research in the department with TBI and flu actually. So that was really fun to be able to wear so many hats. I left and went to community medication. I left and went to community medicine. And then academics followed me, and I became an EM program director at a community hospital in North Florida Regional Medical Center in Gainesville, across the way from UF, actually. I am currently the acting chair of the department. I just keep getting myself into things. The program director, and I am involved in FCEP, which is the Florida chapter of ACEP. I was on the board, and now I'm the chair for the Medical Student Council, and I'm here basically to help in any way I can for Florida medical students. So that's kind of, and then there's like a shameless plug for my residency on the side of it. Okay. So today we're talking about, again, kind of the current state of EM. There's been a lot out there, a ton. There's so much information that I'm going to try to give it context for you, so that you can interpret and understand that information and ask me any questions you want. Mainly, this is focused around workforce issues and some drastic changes in the last 3 years. And a lot of the things we'll hear about is supply, demand, advanced practice, the advanced practitioners in the department, and corporate medicine. How does that play into this? And then freestanding ERs also have a big change or have a big effect on demand for EM physicians. So we're going to talk about some of these, but I do want to give you a little bit of perspective. We are a baby specialty compared to some of the other specialties, right? So we started in 1965, was the first group of doctors that said, okay, I'm done being a psychiatrist and a dermatologist working in the ED department. This is something special. There's a thing about it. And we are going to, you're going to pay us, and we're going to stay here 24 hours a day to completely staff this ED. And then in the 70s, there was the first EM residency, and then EM joins AVEM. And why this is important to you is that, as you have heard of EMTALA, there's a lot of federal mandates that hospitals need to staff, certain types of hospitals need to staff an emergency medicine department, which then provides care for anyone who crosses the threshold, or at least provides an evaluation and stabilization for anyone. And so we have a specialty born. The specialty is born we have a few residencies out there, and then all of a sudden, all the hospitals need to staff an ED. So you can imagine that this is an interesting scenario and not thought of right off the bat. Fast forward to 1995, and you don't have to remember any of the specifics, but just remember that this now is the time when the role of emergency medicine was more defined in America, and there were recommendations that medical schools had emergency medicine departments, and these departments provided education to all medical students, et cetera, et cetera, et cetera. So EM is building up the our specialty and our knowledge base and research, and really growing into our own. And because of this scenario where we were born so recently compared to other specialties, and there was such a demand, we started off basically with a huge physician shortage. That was, I can tell you, since my career started, that has been all we've heard about until recently, is physician shortage, physician shortage, physician shortage. So you have to know kind of the background of where this momentum came from. And so there's multiple work studies that basically identified physician shortage. And then also in this state, in the 1980s, 2000s, there was no growth in medical schools. You should all know, being children probably of baby boomers, I think I have my generation's correct, that there was not a plateau of growth in the population of the US, but there was literally like no new medical schools, hardly any new spots from the 1980s to 2000s. So this was recognized, and the physician shortage was coming. So where did the United States, we put our resources, we need more medical schools. So by 2019, medical student enrollment had jumped 52% higher than in 2002. So that's a boom. That's a big growth, right? So now you have all these medical students graduating medical school. They need somewhere to train to become doctors as well. And now you're seeing kind of the trend of like, this is what was happening in the past. So now the physician shortage spurs Florida specifically in action, because Florida our population is growing very fast, and our population is graying, and gray populations need more medical care than pre-gray populations. So Florida especially realizes that there's a physician shortage. And so you can see in 2013, there was a statewide Medicaid residency program. This means money and resources were put towards starting new residencies. 2015, there's a GME startup bonus program, and EM was included in this. And it wasn't until 2021 that EM was removed from this list. So it's very complicated just to discuss healthcare and how to pay for that. It's also very complicated to talk about medical education in the United States and how that occurs. But you can see that somebody was very concerned about physician shortage. They put money where their mouth was in Florida, and then we got what we asked for. Here we go. So this is just Florida. And in 2007, these were the programs that existed. When I applied for residency 2002 was when I went to residency, and there were 4 programs just kidding. There were only 3 programs in Florida. Because when I came back in 2005, that's when we started University of Florida. Advent Health was, I think, 2007. So 3 programs total in Florida. It was recognized very clearly at that time that this was vast, underpopulated. Like, we need emergency medicine physicians. And it takes years and years and years and years of investment to create the right scenario to start residency programs, to put people in place, to have the right rotations for residents, to have infrastructure, et cetera. So what happened was a bunch of people started the ball rolling, a bunch of different places, a bunch of different scenarios. And fast forward to less than 20 years later, and we go from originally 3 to 22 programs in Florida, approved in Florida. So now you can kind of understand the historical momentum that was occurring in medicine. And now we're in 2020, and I put 2021 here, but this workforce report was actually released to a bunch of people, reported on in 2020, prior to COVID hitting the United States, March 13th, 2020, which is the day that obviously wasn't the first case. It was the shutdown of the United States, because it was a Friday the 13th. And I was working, so I remember this very well. But it was 2021 when this was published and really discussed. So the 2020-2021 era was like it was a very terrible time for EM, in the sense that COVID completely changed how we practice, completely changed it put us at great risk. And it's hard to remember that now because of the current variant. Is very different from the Alpha and some Delta variant, obviously. And we know so much more about COVID. So back when this hit, really it was going to work every day and not really having any clue whether you're going to catch it or bring it home to your family, or if you're going to be part of the 10% that die from the Alpha variant. You just don't know. And so that was very hard on all of the support staff, all of the physicians, and you guys know this, so I won't harp on that more than saying that. But then add in this workforce study, and let's talk about what this workforce study was. Thinking that you guys are all familiar with this, but this is what really started the ball rolling. The workforce study discusses supply versus demand, and it actually is a really, really well done paper. The people involved did a really, really great job. And what they did was they analyzed supply of emergency physicians and the demand for emergency physicians. They made some assumptions in statistical terms. They made assumptions, and then they looked at the trends and then put those assumptions out to 2030, the year 2030, to predict if our supply was going to meet our demand or go over or be under, et cetera. And supply part is GME growth. The amount of patients seen by APPs in the department, because there was an increasing role for PAs and ARMPs in the department. I said increasing role. And then things that also affect supply is attrition rates of physicians, how many physicians retire or stop working each year, basically. And then the non-EM trained docs, as ABEM or ABEM certified doctors, EM doctors continue to grow, then the role for family medicine doctors who are working in the emergency department actually decreases. And so more EM trained doctors are hired and less non-EM trained, residency trained doctors are tolerated in the emergency department hiring pool. Demand is basically affected by freestanding growth, really affects demand. Because if you have an ED and then you add a freestanding, the freestanding has to be staffed 24/7 by an emergency medicine physician, just like the emergency department. But even if you only get 2 patients overnight, you still have to have an ED physician. So you need about 5 or 6 FTEs per single coverage freestanding that opens. So if you think about that, that actually really can increase the amount of ED physicians needed to staff emergency departments across the United States. The population growth of the United States, the graying of America really affects demand, and COVID really affected demand. If you remember, when COVID hit, I took a 20% pay cut for quite a few months because we literally just didn't even have patients. And that's the way our group does pay. It's like, we don't have money, we don't pay ourselves, we work it out. There were some people fired because freestandings closed, because nobody was going to the hospital. COVID then has affected demand because after people started coming back to the hospital and the first 2 waves were over, we had a plethora of patients. And then during the waves, we had a gazillion sick people. So COVID really affected demand. And the reason why I put that in there is because it is not in any models, because we did not know and we did not suspect that obviously happening, but it was like a huge wild card. And even as it was happening, we couldn't predict what was going to be happening next month. Very unsettling. I like chaos and pandemonium as much as the next girl, EM girl, but that was a lot. So here's the little paper down here, emergency medicine physician workforce projection. And it is such a great paper, but it was like blown out of the water because 5 unpredictable, crazy scenarios having to do with COVID happened before the paper could even be vetted by researchers in EM. COVID like blew it out of the water. So just to talk about this paper a little bit and explain to you, so when you hear people talking about it, you can understand the scenario. These are some of the figures, and you can see that figure 4, for example, in the upper left corner, and this is a QR code to the actual a presentation. Oh no, this is the one to the paper. I have another one later to a presentation of workforce analysis. This one is to the actual paper, Marco et al. So the projected supply of EM physicians assuming no GME growth and bearing attrition. So they have a lot of these charts, and you can see that green means an assumption of 2% attrition. The red dotted line is a 3% attrition. The blue dotted line is 4% attrition. So which one is it going to be? Do we know which one's the most accurate level of attrition? No, but we have to make our best educated guess. But you take 5 factors in the paper: APPs, attrition, residency, GME growth, historical trends of population growth. And then you have 5 different scenarios where you've had to make your best guess. So if you remember statistics at all, which I try not to, honestly, so I do not blame any of you if you don't want to remember statistics. But you are multiplying your variance, statistical variance, by each other. So by the end of this paper, even though I'm telling you it was very well done and they made great assumptions, like well-educated assumptions, you vary 2 of those assumptions by 2% and you have drastically different results. So this paper was dismal because the conclusion of this paper was that there was going to be over 7,000 extra emergency physicians graduating in 2030 and every year after. So the problem with this paper, and the problem in thinking all, like if you're in Vegas and you think this is exactly what's going to happen, and no one does, but there's so many assumptions and so many variants. So this is what COVID blew out of the water. And I made this slide. I'm so proud of this slide. Look at all those graphics I put together. I made this slide because there's COVID, there's this workforce study, there's this growth of residencies that people are worried about. And what they all have come down to, and where you guys are at in your world, is that 2023, we had decreased student access and interest to EM over the last few years because of COVID, changed a lot of contracts with hospitals, ability to rotate in the ED. In your first 2 years, did you even get to go to an ED, et cetera? You have a concern about the quality in education. You have number of qualified applicants decreasing because of this. And then we have these, I didn't know what to call it, so I called it Reddit informants. So we have this social media, we have these people who are on Reddit, and Reddit is it's a valuable resource for a lot of reasons. Just like I think Facebook is valuable for its own reasons. You guys might not even know what that is. It's so antiquated now. Instagram is very valuable. They have all their places of value. Unfortunately, there's also a unchecked alternative facts kind of scenario that can occur and snowball as well. So we have this very interesting scenario in 2023. And because of all of these factors, there were 555 unmatched spots. So we can talk about the match, and we can talk more about the individual parts of the workforce, this specific workforce study I'm happy to do that. That wasn't, I really want to get at what this means to you all and not get into all of that minutia. But I am happy to talk about those things. But this is where we're at now. So what does that mean for you guys? So I'm recapping. We're a new specialty. Then there actually a TV show. This was pretty important. This amazing TV show that made ER look, you guys are probably too young. You've probably seen the TV show, but it was like a cultural swing in, I guess it was the late 90s. And basically it made emergency medicine look like the best job in the world. And then you have this massive physician shortage for a decade of information saying that there's going to be physician shortage in most primary care specialties as well, but specifically EM as well. And then too much too fast. So here's where we are at, and there has been a negative effect. And since that study in 2020 was talked about in 2021, other studies have shown different results. And this is a post that we ended up putting up to give people information. And I have all of these studies will be in the in my references slide if you are super interested. You can definitely look those up. But there's even more studies coming out that are basically, and I don't even want to say refuting the other study, because the other study did such a great job, but they're just using different assumptions that are also well-educated guesses. So it's kind of adding a lot of, there's a lot of turmoil right now because where is the right information? Great question. Glad I asked it. So this, since 2020, this is something that has made me very, very reassured and happy, because before 2021, which is when this Workforce of the Future group was put together, made up of 8 huge emergency medicine organizations that represent so many different factions of EM, came together, created this EM Workforce of the Future. And this QR code is to the talk that explains what the Workforce of the Future, what their work concluded in. And we'll talk a little bit about it. I'll summarize it in the next slide. But basically, FCEP, IMRA, and SAM, and most of all, CORD, those are the CORD is the big organization that I put my trust in. And basically they all came together to start addressing these issues, which is really, really important and shows me that the right organizations with the right people are now willing to and are addressing workforce issue and concerns. So they're going to continually be analyzing what is going on and what the results of each year and what happens. So this group initially got together in 2021 and all by Zoom, and basically talked about recommendations. And each recommendation that they made, these are the cliff notes. What do you guys have cliff notes? What, like these are the smallest of small version without all the interesting juicy details. So each time they looked at a recommendation, they analyzed it for feasibility and impact, because some recommendations are very feasible but have very low impact. Some recommendations are not feasible at all but would have a huge impact, right? And they discussed each of these and then published the information. So some of the supply recommendations to help EM right our ship, basically is how I like to put it, is to increase, this is going to sound odd, but anything from increasing procedure requirements, which was suggested, to increasing the length of training, which does not make you guys happy. I'm just telling you for you, it doesn't make you happy. Increase residency salaries, which makes you happy. Investigate the legality of for-profit funding, which is interesting because for-profit funding has existed for more than a decade, but this is an important something to address. Restricting resident number increases, like in already established programs and new programs. Close current programs with recruitment or board pass rate problems. Redefine EM to increase scope of practice. And at this stage of the game, these are all literally not we're in the stage of investigation of what to do and what's the right thing to do. And this is really, really important to me specifically, to you even more so, because you're younger and you'll be here longer, and you are going to be part of the people shaping the specialty of the future. But in my mind, and why I'm so glad all these organizations got together, they are all looking at our specialty and future patients and future doctors, and all wanting the best thing for the specialty. And I think that's really important, because some of these suggestions are not going to make my life's going to probably be harder with them as a program director, sure, but it's the right thing to do, and we all have to be on the same page. And I'll talk a little bit later about what happened with anesthesia, because anesthesia went through a very similar issue. I want to say 1995 or something. And we can talk about that. So back to this slide, 2023, workforce issues in COVID. You guys are in medical school now. 5 years ago, people in medical school would never have ever, like, this is completely incredibly insane to anyone 5 years ago. And we talked a little bit about supply, a little bit about demand, a little bit about APPs, which are part of the supply issue. Corporate medicine, we haven't really spoken about. That is on a lot of people's discussion plates. And what I have heard, so I guess disclaimer, I work for, clinically I work for GEMA, which is my group. Our residents are paid through University of Central Florida. We're part of their GME, but we are an HCA supported program. So my stipend for being a program director is paid by HCA. So that is considered, would be under corporate medicine. And HCA is very present in Florida, and they have been the most organized corporation to say, we want to start residencies because we don't have enough doctors to work. And they like went about it like super fast and created a lot of residency programs. So in EM specifically, HCA and corporate medicine, including Team Health and some other corporations, have been under the gun for being the problem. And I'm not denying that. There was a lot of programs started. However, it's been very interesting how much we call it a complement increase when you have like 8 residents and you are saying, I want to now have 10 residents a year, so I'm requesting a complement increase. And I'll give you an example just because I started UF program, we had 8 residents. Now they have, I think it's like 14 here. So there's complement increases in almost every single residency that already existed across the United States, almost, prior to 2007 as well. And we have a program started, for example, FSU started a program. We have USF partnering, starting with program. A lot of people are getting in the game. So the question about corporate medicine that I challenge you to keep in mind when we hear about it is, the question is and people are questioning legality, which there has been we don't really have laws against corporate medicine sponsoring EM. What we need to do is look at it. Is it affecting the quality of residents, quality of residencies, and how is it affecting our specialty? So that's how I approach it, because first and foremost, I'm an EM doctor. And then second, I am a residency director, and I've got currently 24 work kids that I'm looking out for. 8 of which will be here in 2 weeks. 8 new ones, super excited. So freestanding EDs, we already talked about that. I'd like to take a little bit of a break here because we're going to talk I really only have like 2 or 3 more slides. And honestly, the discussion is going to be what this means to you. But does anybody have a question right now that I could answer, or a comment that may be helpful to anyone? And I'll hydrate. Okay. Let's see. Let's go on to the next slide, because I did have some comments on the registration about what is the 5-year outlook? And I think that's important to talk about for sure. And it's important to get through the next 2 slides, because if you thought I was waffling on being able to tell you which workforce study was the right one, just wait till this slide. Okay, what does this mean for you long term? I don't know, but I'm willing to show up here and talk to you about it. So why I say I don't know is because I can't promise anything. But what I can tell you is that a couple of things. A, personally, emergency medicine is my personal opinion. Emergency medicine is the best specialty. And it's a specialty I fit with and I love coming to work. So knowing that and moving on from there, I'm going to tell you that there's a lot of evidence that has come out recently with workforce analysis that's a much better outlook for the workforce scenario. The reason why I'm okay saying that is because also our EM organizations are working through this. That is really important. And at this point, I can tell you about what happened to anesthesiology in the 1990s. Anesthesia got into a similar pickle, basically. And it has to do with having CRNAs taking over a lot of their clinical duties and a huge rapid growth of their residencies. That created a scenario where all of a sudden there were a lot of anesthesiologists graduating, but CRNAs were able to take a lot of the jobs that had been pre-existing. So at one point, 50% of the programs did not match in their program or in their specialty. And it took about 17 years for that to completely come back, like after they closed some programs, instituted some scope of practice changes, changed some qualifications of programs, et cetera, to come back and right itself. But right now, anesthesiology is a very competitive match, and they have, in my terms, righted the ship as far as creating a good number of graduates to meet demand. It's an appropriate number. Anesthesiologists have value. They're not just there, and they have changed their scope of practice. And so I want to tell you that this has actually happened before, and it has been fixed. Now, what that means for you guys, very specifically you at this moment and the next 5 years, I think it was Rachel I was talking to about like, what's the 5-year outlook? What does this mean for you in the 2020s? Basically, there's a less competitive match and there's more opportunities for you. And because I do believe, I mean, I have worked with an EM person, and if you knew the dynamic people that are involved with EM leadership and EM education throughout the state and how they are tackling this, the ship is going to be righted. And the other way you could look at it is that you are in a buyer's market. And basically, at this point, real estate has fallen and you have the pick of the litter. So you as a student have more opportunities, you have more choice, and you have the ability with the right plan and mentorship and experience to really take advantage of the scenario that other students aren't as interested. And that's the truth of the matter for you guys right now. So what I would like to do is talk to you guys and field any questions to see if maybe I did answer your questions. And I'm gonna stop sharing so that maybe we can talk. And I know it's late at night and you guys might be, I don't know, in your jammies. So if there's no questions, I'm fine with that too. I hope that was helpful in the sense of like pulling all that information together. So now you have a starting place of where to think about that. We, as in FCEP MSC, we have an Instagram account, and you can DM us with any questions, or if you would like to get in touch. Again, most of you guys, I was able to meet in person, which I really appreciate that. But I encourage you guys to email me or DM us so that we can get you hooked up with a mentor or some specific information. Right, I'm going to stop recording. Okay.